I am an adult ID doctor, so I appreciate being asked to come to a pediatrics conference. Hopefully, I will be invited back. I do take care of adolescents and young adults in my clinic, where I take care of HIV-infected and uninfected at-risk youth, and then my research really is around youth and young adults. So I feel more at home around the pediatrics folks and the adult folks, to be honest, but again, don't tell anyone that. So I get to talk to you about mobile technology for engaging youth in treatment and prevention. Maybe? Okay. And since this is, again, a global meeting, I thought just, thinking about kind of the youth online, and 70% of the world's youth are online. So there, when we talk about a digital divide, it does persist, right? Certainly youth in the US, 94% are online, and you see less as you move to less developed countries. But the divide is closing, and it's certainly a fact that youth in these countries are leading the way in terms of access. So if you actually look at sort of who in these countries has access, youth 13 or 15 to 24 are the ones that are going to lead the charge in having access anyway. So when we think about engaging youth in care and in prevention and in risk reduction activities, we really need to think about using online interventions. These technologies can offer really key functions that are relevant to youth: anonymity, social support, provision of real-time information. And we've made a lot of progress. There's been a lot of work in Mhealth interventions, a lot of funding that's gone out. And we really have moved the needle forward, but we don't yet have sort of full efficacy randomized trial data showing kind of what is the best intervention using technology. So I'll try and give you a sense of kind of what we know and then where the gaps are, where sort of the places where we can improve this. So what about texting interventions? Multiple studies, I think, have shown that and integrative reviews of reviews, systemic reviews of reviews that have been done. I don't know who has time to write these reviews. I can barely write my own just original articles, but there's a lot of reviews that show that SMS or texting has sort of moderate effects. It's feasible, acceptable. People are fine with you texting them. And then there's certain sort of pieces as you do these reviews of reviews that come out. And again, these are things I think just to start thinking is that studies where texts were not sent daily had actually better effect. And again, I think, you can get annoyed with, people kind of sending you texts every day. I don't tell my mother that, but maybe I don't respond daily back, so I thought she'd get the hint. But supported with bi-directional texting. Again, people want a response. You just sort of, they want to feel like there's somebody on the other line. It's personalized. Again, hi Lisa, did you take your medicine today is more important maybe to me than, pill, take it, did you? And then if they're matched to my dosing schedule. So again, if I take my medicine once a day and I'm getting reminders twice a day to take my medicine, it can be, again, lack of personalization and kind of annoying. In terms of sustainability, again, less studies sort of looking out long term. This one did actually look out to 12 months and didn't find that sort of just SMS was sustainable. Didn't have actual outcomes that supported, and again, this was adherence and a Bactrim prophylaxis. Again, in this study, messages were, they compared sort of unidirectional and bidirectional, no difference, but they were not personalized, they were not tailored, and the content was not sort of something that youth necessarily found sort of interesting. So again, important to kind of think about this as you move forward in thinking about SMS. Again, what's next for text? I just had to use that because I thought it was cute. So I think, I don't think you need to test, again, my opinion, not supported by anyone other than me, but I think that we don't necessarily need to do any more interventions that just test whether a text message intervention is acceptable, feasible, I think we know that. I think we should think about how do we implement them in other interventions. And this is a study, a cluster randomized study, which is doing just that, and really is looking at including SMS in another package, because again, it certainly doesn't hurt to remind folks, but it is important to, think about the other pieces of the interventions that we want to engage youth. Also, I think, embracing other formats for delivery. So again, I don't know how many of you have kids or think you're a kid or want to be cool and hip, but youth rarely just sort of text like hello, how are you? What are you doing today? There's GIFs, there's emojis, you know. It took me a couple years to learn that it was a GIF and not a GIF. There's memes, you know, all kinds of cool things that youth do with imagery. So sending texts that are just, you know, hi, how are you, is not going to resonate as much. So again, thinking about kind of other cool formats to engage youth that is Beyonce, I think. Showing how, you know. Again, you know, thinking about ways to move texting forward. It doesn't always have to just be text-based. I also think we know a lot about sort of what youth want in terms of other features of apps, right? We've done a lot of focus groups. Again, I have a colleague that says, please don't make me do another focus group. And she's a qualitative researcher, so you know, I agree with her, but I'm not qualitative. But there's been a lot of work, again, and not just in the US, but globally, again, out of multiple countries, looking at preferences in multiple populations of youth, young MSM, young women, and I think that we have a really good, solid list of what folks say they want. All right, and that doesn't necessarily mean that we don't need qualitative research. I was being a little facetious, but I think that we know this, and this should be the place where we start when we're doing our research. We don't need to not pretend like we don't have some information. Youth want to connect with peers and providers. Inclusion of discrete reminders. Again, nobody wants to get a message that says, hey, did you take your HIV medicine today? I don't think we need to ask that anymore. Provision of sort of comprehensive, holistic information. People's lives are not just about, and my slides will be made available. You feel free to take pictures, or you can just take pictures of me. But I will, and anybody who wants these slides, I'll email them to you, so feel free. You know, they don't want just information about HIV. Our lives seem to revolve around HIV, and it becomes very important, but these, you know, youth lives revolve around more things. They want information about how to talk to partners. Can they have, you know, sex if they're positive? How to disclose their status, or just how to stay healthy. And so we need to think about kind of including that. Games, rewards, incentives, I'll talk more about this. Make it fun, and then careful attention to privacy and confidentiality. Again, these are things we know, and I think we can use this as a starting point rather than starting from the beginning. My caveat is that most of our studies still focus on youth that are sort of older. So there's very little work on the youngest of the young, and there are differences between perinatally affected and behaviorally infected youth in terms of disclosure and meaning of disease and sort of, you know, the medications that they're even taking, whether they're sort of a single tablet regimen or more complicated. And so I think we need to, you know, certainly think about kind of this in terms of the design of our interventions. Again, a few examples are sort of around youth autonomy, and this was a study which looked at sort of mobile phone ownership, and it's not just around ownership, right, but it's around sort of monitoring. So again, youth that are younger may have more parental oversight on their phones, and so, you know, thinking about interventions, it's important to kind of have a better understanding of that, sharing phones, or, you know, taking away phones if you get punished. So again, I have an 11-year-old who's like obsessed with video games and Fortnite. Again, I don't know if any of you have that, but when he's like mouths off or is, you know, immediately he loses Fortnite and like, you know, so, you know, immediately my punishment is to take away his electronics. And so again, if a youth is, you know, has that parental oversight and their punishment is to take away an electronic, which is where the intervention is being delivered, that's something we have to consider. So Agile development, you know, again, put this in any grant. NIH and reviewers seem to like it. But sorry, my NIH people are back. Now they know my secret. But the truth is that, you know, the idea of Agile development is that we make changes based on feedback. So, you know, my motto in sort of doing this is don't ask a question that, like, if you get the answer, you're not going to do anything about it. Right? So I've stopped asking people what color they want their like intervention to look like, because by and large, you know, purple, pink, black, green, you know, I can't make it a rainbow of colors, although that would be a cool app. But so, you know, think about kind of what is the feedback you want from your audience? Where are you going to see the big, you know, bang for your buck in terms of making changes? And then ask those questions, and then actually do something with it. Right? And learn from your users, because if the users don't think your intervention is of value, then there's really no reason to do it. So really kind of make sure that you're talking with users. So how do we maximize uptake and engagement? I think, certainly from sort of the larger level, in terms of sort of aligning Mhealth priorities with those of the location where you're doing it. This was a WHO survey, again, 2011, but the largest barriers to global Mhealth was aligning with priorities. So I think really kind of, depending on what your location is thinking about how to align. Again, incorporating youth-focused engagement strategies, and I'll talk about each one of these. So tailoring. Again, tailoring increases the relevance to an individual. And we know, again, from these reviews and again, if you all, I'm not knocking the reviewers and the reviews, but we know that tailoring increases the relevance and increases maintenance of behavior change. So again, thinking about tailoring is important. I'm going to show you an example from the Adolescent Trials Network, which is sponsoring my center, a center for innovative technology called iTech. And so this NIH-supported grant that I have, we're supporting 10 studies using technology across the care continuum for youth. Get Connected is one of them. And Get Connected is a motivationally based brief online intervention that uses individual and systems-level tailoring to provide information to youth around where to test. And the cool part about Get Connected is it actually does this. It first has mystery shoppers go out to all the testing and counseling and testing locations in an area. This is from, we're first doing it in Philadelphia, and then in Atlanta, and then in Texas and Houston. And they basically are secret shoppers. They go in and they see what they're offered. They rate the facilities. Then they put this information back. Give this as a report. They go to all the facilities multiple times. Then we collate all that information and it gets incorporated into this app. And then youth are recruited to sort of be in the study and they get on the app. And they're asked a bunch of questions up front. So, age, race, ethnicity, all those sort of good things. But then also other things that we should think about tailoring on. Structural issues, right? Values, sources of support. And these are two examples. So the first is a case one, is a 19-year-old black, single. Again, you can see different values. And the second one, again, is 22-year-old, Latino, has been tested. Again, different values and barriers. And what you can see is when they log on to the Get Connected site, they get two different sort of messages. Sort of the first one is sort of why Get Connected, and then has information, again, that reflect what they put on the intervention versus what the other person said. Again, you can see what's important to you. Again, for the one that said, feeling sexy and strong, that's the information they get, versus somebody who identified other values like religiosity, responsibility. You see they get that information. And again, then what they get at is, again, sort of how do you sort of make sense of this is getting information about kind of testing. And again, what gets spit out is more personalized, tailored information about testing. And it's hopeful that at the end of this, those that get this individualized information will test more. All right, theory is also important again, so thinking about kind of all the different theories that we use, really thinking about how that might motivate change. Social support. Again, we know that youth, a lot of youth may not have social support from their families or even from their friends. They may not have disclosed. So how do you create communities where youth can get the support they need around these issues? And I think there's been a lot of work done, but I think we're still figuring out how to do this online. How do you build a community that doesn't exist? Facebook or WhatsApp. There's already sort of these established communities where youth are living and breathing and engaging, but they may not be engaging around the topics that we're sort of wanting them to engage with. So how do we recreate this idea? Again, another intervention from the ATN U19 iTech is You Thrive. This is an intervention for all HIV-positive youth who are failing therapy. And again, it's all driven by, again, it sort of looks like Facebook almost, if you can kind of see the posting, but it's really driven to create a peer-to-peer interactions around risk reduction and medication adherence. There's, again, a lot of other features, and we've really worked hard within the ATN to, this was an adult intervention called Thrive With Me, to make it much more youth-friendly. And again, if you looked at the adult version versus this version, this one is much cooler, again, much more relevant in terms of what youth are using to date. So we're getting ready to launch a field trial testing this, and then onto a larger RCT later this year. So game-based elements, again, this is another thing, we put in our grants a lot. But again, if you're going to do it, make sure you really sort of know what you're talking about, because I think, reviewers are getting more savvy when you say you're going to gamify things. But the idea is really sort of to make something that wouldn't normally be fun more fun. So putting game-based elements into it. And there's, again, a whole, litany of ways to do it. So I thought I'd just talk about kind of just a few of the ones and some examples in terms of lingo. So points, again, and if you play any games on your phone or have any of this in sort of other, other things, frequent flyer programs are gamified, right? The more points you get, the more levels. I used my points to upgrade here. It was nice. So I was very happy with my gamification in Delta. So points, again, you accumulate them by doing things. And then badges are sort of more instantaneous. This is, again, and these are all examples from work we've done. The one on the left is from Epic Allies, which was an NIMH grant, a funded grant. And then Links is from the ATN. But again, in Links, they got this badge. This person started PrEP as part of their intervention. Rewards, again, that can be virtual, so something you get in the app, or something you can collect afterwards, so a coupon, some money. Leveling up, again, showing progress. You leveled up to, another level. You're making progress through the game. And then leaderboards and competition. Again, we all want to be, the best, so it can be competition between ourselves or competition with others. Again, systematic review. And what they found was that gamification, again, this wasn't specific to HIV, it wasn't even specific to youth, but did show that gamification did increase engagement. Again, effects seem to wane over time. People get tired of things, right? You may not, necessarily be doing the same thing, 6 months or 12 months now. You may not even be playing the same game, right? And so, again, we have to think about how do we maximize engagement, and the question may become, do we need them to be engaged for 12 months? Is 3 months enough? Is 6 months enough? So maybe it doesn't matter in terms of long term if we can get them to sort of engage in healthy behaviors and create the habits they need. This is just, again, another example, shameless self-promotion, clearly, but from work we're doing in the ATN, this is P3. It's a really kind of gamified app. This is our app to increase PrEP adherence. We also now have an R21 to develop this in Thailand, so we're really excited about that. And also builds off of work we've done for positive youth. So same platform, multiple ways to change it to make it sort of country and context specific, but has a lot of features for gamification. Again, self-monitoring and feedback is really important to introduce sort of behavior change for youth. Asking questions, tracking, and then providing feedback. Again, builds into kind of the idea of theory around behavior change and increasing self-efficacy. So again, another thing to think about as you design these interventions. And then again, push factors. Again, these are email prompts. Again, that's my dog behind that. Sorry. So that's some messages I get from P3, are the intervention I showed you. But again, you can see none of them say, did you take your HIV pill? They're very discreet reminders, and they tell me that I'm low on my refills and I haven't taken my meds. I think that the key thing in kind of the last few minutes is just making sure as you move forward that you're testing whether the intervention is effective. Scale up really should be preceded by these types of trials, and if you can't do RCTs, thinking about other new ways, step care interventions, other types of trials. And it's important, again, to remember that online interventions can collect a lot of information in the app, where people go, what they do, how they respond. But we should make sure, again, when we're doing this, that we're thinking about that beforehand. And again, this is sort of a newer field called Paradata. And the idea is that you really want to make sure that whatever you build has the capacity to track what you need it to track. So at the end of the day, you can decide if that intervention or that component of the intervention is effective. And again, I would highly this is really a conversation between yourself and your technology partner from the very beginning. Here's an example this is just from a small trial we did, an AllyQuest trial, of an example of what Paradata can look like. This was sort of number of logins. And again, you can imagine as this trial gets to be like 500 people that, me sitting there trying to parse out, lines on a graph like this is not feasible. I've done it, but it's not, it's probably not, as good quality. But so really kind of understanding how you're going to get that information, and then how to compare it to other studies. So again, within iTech, one of the things we're doing is creating comparative and standardized measures of usage for technology-based interventions, so that at the end of the day, we can compare our interventions across the board. Again, whether they're HIV-related, whether they're focused on other chronic health diseases in youth. Again, I think as we move forward, I think we're thinking about scale up and sustainability. There's a lot of importance of stability in finances, technology, partnerships, and you have to think about this sort of from the very beginning. So stakeholders, really, again, it's just important to think about it. And again, we've started to do this within our work. We have not yet kind of taken an intervention to the highest level of scale up. So it's something we're starting to do now as well. But in thinking about, again, who's going to implement our interventions if it's successful? In the world, if P3 makes all young MSM take PrEP, like, how am I going to get this out? That would be my dream, right? So will the health departments do it? Will the CDC do it? So we have to start talking to those folks and figuring out how to make that happen. And considering costs. Again, in all these reviews, what they found is that no one's really looking at cost. And again, something I write in all the grants, which seems to fly, is that once developed, Mhealth interventions are cost effective. We don't know that, that's made up. Again, I think we need more data to show that. I think we believe that, but they're not free. You still have to monitor them, and somebody on the other end has to make sure that they keep working. So we need to have better measurements of cost. So I think opportunity awaits. I think the field has learned a lot, and I think we can certainly look to what's known to build. And again, I think usability, affordability, certainly need to do that. Scalability, sustainability, long tail accessibility. I had no other ilities, or I would have added more, because I was clearly on a roll. I think that we have a lot of room to expand, both in the US and globally, in this field. And my hope is that we can, again, build more collaboration so that we stop building new apps. We stop creating new content. Instead, we look to each other I have 7,000 articles written about HIV treatment and adherence and depression and mental health and social support and smoking and drugs, right? And STDs. There's no one should have to write another article about the symptoms of gonorrhea. Like, call me. I'll share my articles about gonorrhea. Because it takes a lot of time to write content, right? It's a piece of this that we don't talk about. So again, how do we sort of move forward in collaboration with each other to move the field forward and again engage youth in treatment and prevention? 1 minute. Thank you.
Thank you.